Hello, everyone. This is Catherine Mather, and I'm pleased to welcome you to today's webinar, What Matters Most in Driving Cross-Sector Partnerships for Complex Populations. Next slide, please. So before we get started into the meat of our content today, I just wanted to do a little context setting and introduce the playbook. So it's widely recognized, and I'm sure that this is not news to many of the people on the call today, but it's widely recognized that the health system, by health system leaders, researchers, and policymakers, that a small percentage of the total population generates a disproportionately large portion of healthcare costs, and that those small percentage aren't necessarily receiving great care either. But the good news is that the growing concerns around costs and poor outcomes and piecemeal approaches to care have given way to a movement to address these systemic issues on multiple levels. And there's more and more great examples every day of promising practices, comprehensive care models, and programs, many that have shown preliminary results in improving health outcomes while also reducing costs. And while this evidence is still evolving, many of these programs are meaningfully improving people's quality of life, which we can't discount that. So as part of this movement, a group of 6 foundations, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, the Peterson Center on Healthcare, Robert Wood Johnson Foundation, and the SCAN Foundation have formed a collaborative committed to accelerating health system transformation. And one of the many pieces of work that this collaborative funds is the Better Care Playbook. This playbook was launched in 2016 and is coordinated by the Institute for Healthcare Improvement and the Center for Healthcare Strategies. The playbook is a robust online resource center that offers the latest on evidence-based and promising practices for redesigning systems so that they better serve people with complex health and social needs. And included in the playbook are many practical how-to pieces of guidance to inform health system leaders, payers, and policymakers, and others on strategies to improve care for people with complex health and social needs. Next slide, please. So just also wanted to say, as we're going through the presentation today, we are always looking for promising practices on the playbook. So if you're doing any work in your setting, we'd love to hear from you and encourage you to submit any case examples or peer-reviewed publications that you've worked on. Really the whole spectrum. We welcome content submissions to the playbook, and you can learn more about how to do that by visiting bettercareplaybook.org. So without further ado, I want to bring us to what we're all here for today. And one strategy that's known to lead to better outcomes for patients with complex care needs is when healthcare providers work locally with community, government, and other partners. And that's why I'm so pleased to welcome you all to this webinar that we're co-hosting with the Camden Coalition's National Center for Complex Health and Social Needs, where we'll cover how to establish cross-sector partnerships. So without further ado, it's my absolute pleasure to introduce you to our moderator, our facilitator for the day, my friend and colleague, Lauren Harden. Lauren's the Senior Advisor for the Camden Coalition's National Center for Complex Care, and she will be guiding us through the conversation today. So Lauren, I'll hand it over to you.
Thank you so much, Catherine, and thank you so much to you and the funders for all of your support for this work. I'd like to take care of just a couple of housekeeping logistics to start the webinar. This event is being recorded. Following the webinar, the recording and a copy of today's slides will be shared on the National Center's website. There will be moderated question and answer session at the end of the presentation today. So please write down your questions or feel free to chat them or use the Q&A button at the bottom of your Zoom screen to submit a question. So I'm honored to be with you today. I'm a nurse and senior advisor for the Camden Coalition's National Center for Complex Health and Social Needs. In my role, I have the opportunity to partner with sites across the country, building cross-sector collaboratives. And as a nurse, I've had the opportunity to do that as well in hospice, palliative care, and in building a complex care model. I'm joined by 2 esteemed colleagues today who will be sharing their deep experiences as well. Victor Murray, Director of Field Building and Resources for the Camden Coalition of Healthcare Providers, and Shelley Trumbo, Community Integration Vice President for Adventist Health. Victor is the Director of Field Building and Resources at the Camden Coalition and focuses on partnering with communities locally and across the country to design and implement data-driven care models. Shelley is the Community Integration Vice President for Adventist Health System, which has clinics throughout California, Hawaii, Oregon, and Washington. She leads community well-being strategy and provides coaching, technical assistance, and system design for each Adventist health community. So with the Camden Coalition and Adventist, both have gone very deep in building cross-sector partnerships and really looking at what is an ecosystem of care for vulnerable populations. Our purpose today is to inspire the development of more cross-sector partnerships for complex populations, identify common challenges and best practice solutions for establishing and managing cross-sector partnerships, to engage participants in thinking about ways to build cross-sector partnerships to advance the work. We'll focus on the work of the Camden Coalition and Adventist Health in building cross-sector partnerships, but we also want to open it up to your questions and interests because we've all been involved in a lot of different kind of partnerships that we'd love to share with you about how we successfully built those. So next slide, please. So Catherine referenced this data. 5% of the population actually accounts for 50% of the costs in the healthcare system. We've all spent many years serving this population, and what we've learned very deeply is that 5% often has social needs and other things driving their high costs that are not necessarily medical. Medical is very important, but paying attention to the community, trauma, other components of people's care is very important for really impacting that cost. Next slide, please. The Camden Coalition surveyed patients and asked them what mattered most to them and what did they want healthcare providers and social service providers to address in their care. They identified 16 domains of care and really only 4 or 5 of them are medical. This is what matters most to patients. Next slide. So this data is also coming out much more broadly nationally. The impact of social determinants of health, things like safety, poverty, neighborhoods, connection, treatment for things that are non-medical, and supports for things that are non-medical actually have a very big impact on our health and stability. We're going to be talking about those things and how that facilitates the importance of really building strong partnerships across a community so that we're solving problems together and really improving the ecosystem overall. Next slide, please. So Victor's going to talk about the Maslow's hierarchy of needs and how that plays out with complex populations in the community.
Yeah, so we know from Maslow's hierarchy of needs, pictured and outlined here, that in order for people to really reach their highest level of well-being and self-actualization, that foundational needs have to be met. Things such as water, housing, food, shelter, these are very concrete core needs that have to be met in order for individuals to achieve well-being. And so the field, whether that's through the development of interventions, models, delivery systems, are really starting to think about how do we address social determinants or social correlates of health as a key strategy in improving the well-being of individuals and as a strategy in managing costs for the population.
So on the surface, you may be seeing social determinants of health needs like housing, transportation, food insecurity is a big driver. Social isolation is a big driver. Underneath the surface are system barriers that actually impact people's ability to get stable. Things like not being able to have access to services, disorganized services, disconnect between medical, social, and behavioral health services across a community. It's important to understand social determinants, but it's also important to understand how can we connect better with each other, because some of the most vulnerable people in our communities are falling through the cracks because of the system itself. Next slide. So how do we start to change this? All of us have learned that one of the fastest ways you can facilitate and understand what needs to change is to actually talk to patients and families, or be a patient yourself and experience the healthcare system. If you understand someone's story deeply and start to ask questions about more than medical needs, start asking about food security, housing, transportation, safety, loneliness, you'll start to see a new story that brings forward the need to build partnerships with people you may not have thought of in your circle. We're seeing really important partnerships build across communities, of course, with behavioral health and social services, but also with police and EMS, the sheriff. I got a call from a city councilman the other day who's interested in building a cross-sector partnership. Listening to stories and paying attention cross-continuum to who might be valuable partners for you to build relationship with to really change the system is how we start to get to key collaboration and partnership. Next slide. So what are the key features of cross-sector partnerships? What does it take to really establish these partnerships in ways that work for patients, providers, health plans, and community-based organizations? It's widely recognized that good outcomes are achievable when we work together. And cross-sector partnership is a very effective way to stabilize health, decrease unnecessary utilization, and improve care delivery and reduce avoidable costs. Shelley and Victor, what do you think are 2 to 3 key features you've seen of cross-sector partnerships?
So I think a couple key features to cross-sector partnerships that I've noticed across the country and even in our work here locally in Camden is one, building trust among partners, and 2, being able to establish a shared vision among collaboratives and among the group. And really just being transparent when it comes to conversation. Taking stock of, what do we do well as a community, but also what do we not do well as a community, or areas that might be opportunity for growth or opportunity. Oftentimes in these conversations, you have well-meaning individuals that represent well-meaning organizations, and there's a measurement of why we opt in to the conversation, but also considering what will cause our institution to opt out of the conversation. Oftentimes there are organizations with perhaps competing interests, perhaps competing or providing service to similar market shares. And so there's a need to really be transparent and upfront about why we're here at the table, but also why we opt out.
That makes a lot of sense. So let's talk about bringing together the pieces. One of the features of good cross-sector partnerships is really understanding how do we link together, how do we integrate not only medical needs, but social determinants of health, and create goals that really help people stabilize and be surrounded by an ecosystem that cares about them as an individual and really starts to solve root cause for patients and families. Shelley, why did Adventist look at cross-sector partnership?
Well, I think we began, like most other hospitals and healthcare systems, that we automatically are viewing our complex, most vulnerable patients through that clinical pop health need. We're setting disease management programs, and we're really doing it from that egocentric perspective. But if you think back to the slide that had the iceberg, we really recognize that the system always wins. And we came to the point where we realized if we really wanted to make a difference in the lives of these individuals, we were going to have to step outside the walls of our hospital. And that's not always where health systems are really comfortable. The system in your community is designed to get exactly what it's getting. And so I think it takes tremendous discipline and ongoing discipline for a health system to understand and learn how to share power with their community partners and build that trust. It's kind of counterintuitive, but the way to improve health outcomes most quickly and effectively for these individuals is through building trusting relationships with your community partners and really prioritizing that.
I think that's so key, Shelley. That's so well said. Just like building trust with patients, an authentic healing relationship is key. The same principle applies, I think, when we're building these cross-sector partnerships and really building an honorable relationship with each other. So let's talk about the toolkit or the toolbox of things that actually are the concrete components that you can consider if you're going to look at building a cross-sector partnership. One of the first things that's key to have is a shared mission and aim, sort of that burning platform. Shelley, can you talk with us about how you built that? Next slide, please.
Absolutely. I think it began from the perspective that, we often send out an email, a template email to 50 community partners and somehow expect tremendous buy-in and engagement with your coalition. And if you go back to what I said earlier, that your work will accelerate at the speed of trust, I think a first toolkit is deciding that this is where you're going to go deep as an organization and invest an inordinate amount of time in careful communication, in building those relationships, in in-person invitations, and ensuring that the outcomes and the shape of your coalition and your project truly reflects everybody who's sitting around the table. We sometimes come out at the outset saying, this is what we're doing, this is how we're measuring it, this is what we're going to do, and then we become annoyed when our partners aren't willing to invest, the staff time or the resources into the work. You have to take that time at the beginning to build that early buy-in. And really, I think the best statement of success is when multiple partners in the community believe that they own the initiative or they started the initiative. I mean, that's when you're really going to have that traction. And then a second point I would just make on that regard, referring back to what you said earlier, Lauren, about really assuming good intent of our partners. We have this concept of our clients that, we assume good intent and we have faith in their path and their progress. And yet when we're sitting across the table from our community partner, we're really quick to throw each other under the bus and not assume that good intent and, not believe that we're on the same path. And so I think it's, like you said, really honoring the history and the commitment and creating that shared path together that everyone can own.
I love that. And that's something you can do in a small group, in a big group. You can start just with that and having a conversation, which can actually start really big changes happening. Next slide, please. Another tool in the toolkit is to think about asset mapping. So having worked in a lot of different communities and environments, I found this to be so helpful in really targeting the work and really building an effective cross-sector collaborative. So asset mapping means looking across the community to identify what are the resources that the people you serve are going to need for stabilization, for improvement in health and well-being. What are those resources? And do those resources exist in your community? And also, who might be your partners in the community? Who else is intersecting with the patient or population that you're serving? I find it fascinating across the country how many different silos of people can be working with the same patient or the same family and not talking to each other. We can get so much more done by collaborating. And sometimes it's, if you start with asset mapping from the patient's perspective, what resource do they need and who might be your partners, you can utilize that as a tool to start to build a roadmap towards the cross-sector collaborative. There's a wonderful play that was released on the Better Care Playbook today with an article and also some concrete examples of how you can build that in your community. Let's look at another tool. Victor, can you tell us about how you built data sharing in the Camden Coalition and in sites across the country?
Yeah, and so data sharing is another great tool to be able to establish cross-sector partnerships. Really, data sharing, it helps to create a more complete picture of the people that we work with, but we know that this can be both difficult and challenging for a variety of different reasons. When we think back to that slide that highlighted the 16 domains of care, that represented, 16 areas where patients that we work with may touch, but that also represents different relationships. It represents different organizations, that represents different sectors that may have different priorities, which may have different agendas. And so to be able to work through all of that, to be able to align on data sharing agreements and what a true collaborative will look like can be a challenge. And so there's really a strong need to identify shared needs, right? And so as we acquire data, what will we be able to achieve as a group and as a community better? And also just building on existing partnerships. And so as you build on existing partnerships, this allows for a deeper sense of trust and a deeper sense of community, so that no organization is looking at the problem from their own institutional lens, but they're looking at the problem from a community level. They're looking at the problem from a population health level. And so how do we more broadly strategize and use our community resources in order to address this gap, or in order to address this need? And there's also just a need to be very tailored in terms of communication with the proper audiences. And so thinking about why is it important for my institution to be here at this table as this decision is being made, and thinking about the investment and the resources that it would take in order for our community to achieve goal X. And really being honest about your resources, your limitations, and your boundaries as an organization. And so we'll talk more about the challenges and the benefits of including data sharing as a tool later in our discussion, but those are just a few brief comments. And so when we think about data sharing and just continuing that conversation, again, there's a need to continue to be very strategic in how we're collaborating and designing these different structures. Data sharing, again, is a great tool, but there are a variety of challenges that can be built within. And so there's really a strong need to build structures and to have structures in place for this cross-agency data sharing to really occur in a real fruitful manner. And so a first step to building meaningful partnerships between organizations is really examining the challenges of each organization and the challenges that they may face as a result of missing information, and then finding ways to address those shortcomings through data sharing. And really taking time to discover our shared purpose as a community and as organizations. Why are we being incentivized to work together? What is our incentive in being here at the table? And, in this conversation, we can't emphasize enough the importance of having that shared purpose and common goals established very early on in these collaboratives, and really establishing, how would we like to move forward as a group. Specifically around data sharing, the conversation can be sensitive for a variety of different reasons, but really, again, initially aligning on what will be our ideal state at the end of this collaborative or at the end of this working group. How do we start to envision or aspire for better community health, regardless of what priorities or what interests each of us may have as individualized organization. And then, taking stock of the infrastructure. And so how do we manage the work, and how do we manage these relationships? And so this means defining roles. This means deciding, who's accountable for what, establishing timelines, and really establishing accountability. And so structure oftentimes creates the place where trust starts to build. And so there's a need to have a backbone agency, which will continue to help in moving along those milestones.
And Victor, there's several questions coming in about how you protect confidentiality with data. And I wondered if you wanted to address that, since there's several questions coming up about that.
Yeah, protecting confidentiality is important. And it's important to have a credible messenger for that body of work. And so oftentimes after setting that vision, and in this particular collaborative around getting behavioral health providers access to our HIE, we had a conversation about, vision, but then we also had a conversation about, legal ramifications. Oftentimes when you have these conversations, you have, clinicians or administrators in a room, and they're not completely, they don't have complete knowledge of what are the legal ramifications. And so a lot of our work in this space has been educating our partners around those legal barriers and challenges. And we'll come back to that more in our Q&A discussion a little later in our discussion. But just to, again, continue to highlight some of those frictions that take place within these partnerships. A lot of it is around laws and regulations. And so even healthcare organizations, which might oftentimes have a good grasp on the regulations, may just need time to work through compliance needs. And so really establishing, partnerships for data sharing could be a slow process. And so partner organizations that previously have not had these data sharing agreements may also need time just to build their own infrastructure and to develop their own internal processes and to establish trust with data sharing partners. And then you have groups on the other end at the spectrum, organizations that have a lot of experience with data sharing. And then we have to, recognize the fact that each sector has different compliance and data security regulations that may too take just time to navigate. And so patience is required, specifically when we think about community-based organizations and the gaps that they experience, not always having the resources to be able to allocate to these particular groups, or just that data infrastructure piece by itself. And so, again, it takes a lot of time, a lot of patience, and those very transparent conversations up front about what resources do we have or not have to be able to contribute to the collaborative.
That's very helpful, Victor. And I think another really important tool for building cross-sector partnerships is really sharing outcomes that matter to all the members of the partnership. So Shelley, would you talk to us a little bit about how you use 4-quadrant outcomes to drive the success of your collaborative?
Absolutely. Early on, we identified an outcome that was either on one of our partners' quality improvement strategies or a required measurement that they have for their work. So we made sure that every single partner around the table had a data point represented that mattered to them. And of course, cost is an important one that tells a great story. So we were able to show changes in our Medicaid shortfall, appropriate fee-for-service outpatient revenue that came in. We were under capitation agreement here. So all of those things came into the cost category and were built into our dashboard. For utilization, we're able to look at the quality angle for healthcare, lengths of stay, appropriate specialty care, but then we also dug into jail days, police encounters, emergency transport. So making sure that the community partners were also seeing themselves reflected in those outcomes. We saw readmission rates, measurements around disease management, quality improvement standards, and then we had a really interesting, thanks to Lauren's ingenuity actually, where we did a survey of not only looking at patient satisfaction, but also at provider satisfaction. So we had a survey for behavioral health providers, case managers, as well as those inside the healthcare system, asking them, how is this project meeting their needs as well as their patients' needs? And especially in our rural communities, the conversation around provider burnout, health and wellness of providers, provider recruitment, you can begin to connect the provider experience and goals around provider recruitment and retention to having initiatives like this that give them some hope that there's partners in the community that are lifting some of the burden from their shoulders for these extremely vulnerable and complex patients. And so that became a great part of our data dashboard as well. And we had initially, we updated our dashboard monthly, and that helped us build that cadence of momentum and excitement so that next month when we're gathering around the table, we're hearing comparative, last year, where was the patient, where are they today in terms of these numbers? And even though some of the early wins were very small, it still started to build some excitement and energy and built that community agency where people sitting around the table began to feel like, hey, we actually can do this. We're making change. We have the ability and the capacity within ourselves to figure out ways to improve the system and improve outcomes for these patients.
That's really helpful. So there's a wonderful opportunity and an amazing collaborative that Shelley's going to talk about in detail called Project Restoration, which is built in Lake County, California. Next slide, please.
This project is really the first example.
Opportunity to...
Sorry, Lauren.
No, you go.
Sorry about that. This project was really Adventist Health's first effort into piloting an initiative that really was that cross-sector collaboration to support vulnerable populations. The picture that you see on the screen are all the individuals that were responsible for launching the program. And as you can see, there's reflected there people from all different agencies, all different roles, from city and county leadership to sheriff to jail to faith community. And so you're really seeing the ownership of the project between all of these individuals, which was a really important part of it. If you can go to the next slide. This is a quick glimpse of the outcomes from the initiative that we saw. You can see hospital reduction, 44%, reduction in community services, 83%, and overall cost reduction to the community of 71%. And if the next slide continues to talk about those outcomes. So we saw an increase in primary care visits, which of course we know is an indicator of appropriate healthcare utilization, and an increase of 133%. And then an increase in sustainable housing for the individuals enrolled in the program by 93%. So you're kind of getting a glimpse at what that dashboard looked like. And I thought maybe what I would do, I know from my perspective, whenever I'm sitting through these kinds of webinars or conference sessions, I always ask myself, these ideas are great, they're inspiring, they make me want to run out and change the world. And I always wonder, what do I do on Monday morning to get started in the right direction? So I thought I would just finish up this segment with a few succinct lessons learned. The first lesson that I like to talk about, I frame it in the word community. And the idea here is for hospitals and health systems, if they're the ones launching this, to really force themselves outside the walls of the hospital into the community. And I think also not only community in the way we define it of our community partners, but that sense of community. Prioritizing in your meetings and the way you convene a tremendous sense of optimism, and just reiterating that over again, reiterating your early wins and building that optimism is really, really important. But just a reminder to step outside the walls of the hospital and not do it through that usual lens of intensive case management in our clinic spaces. The second lesson I like to frame in the word constraint. I know for me, and I think probably for a lot of people who would be interested in a webinar like this, we want to go big. Right away, we're making claims that say, we want to change the trajectory of 1,200 of the homeless individuals in our community, or we want to take 500 of our top utilizers and change their trajectory through these kinds of initiatives. And the discipline of constraint, of starting small, is so important. First of all, people are often afraid. A lot of our systems and agencies are afraid to move forward when we're talking about really big numbers. But when you're talking about one person, what about if we piloted it with one individual, establish some new processes and systems within our community with one individual and just see what happens. And then from there, you can frame it larger and larger. That kind of lets you start small, a little bit under the radar. It lets you manage expectations. Instead of going really wide and shallow, you go narrow and deep and just start really small. Over time, those wins, you're able to build on them, and then momentum begins and you can grow. So I think having constraint in the way you approach these projects is really, really important. The third lesson is communication. You know, a lot of us are really focused on the work. We're focused on the processes, on the intensive case management, on the research foundations, but you can't overemphasize the importance of prioritizing communication, branding your initiatives, the language, the unique language that you use to describe what those are. You know, changing the way we talk about our partners around the table is just critical and important. And then the last one I would just refer to as content. And so, or context, excuse me. Thinking of context, understanding that there is no way that we can begin to address these challenges that are facing our communities solely as one agency or even two agencies. We have to absolutely take an ecosystem approach if we are going to make any kind of dent. So those are just 4 lessons that I think we learned in that process that I think are important to think about as you begin.
Yeah, and I might also just add to that, Shelley, that, you know, oftentimes you have some communities who have limited resources, and so, you know, how do you move this work forward when you have, you know, low resources? How do you continue to promote, you know, these type of collaboratives, or even promote data sharing partnerships? And it's important, you know, when we think about data, oftentimes we think about, you know, big data, but when you really start to drill down to the most important piece of data, which is really the patient and the individual, and think about how are we really designing an intervention, a model, or a collaborative around that person to move them forward, that sphere of data becomes smaller, meaning how do I now share data around the individual in order to help this person meet their goal. And so what might that look like? Well, that could be something as simple as care planning across community programs. And so, you know, my institution, we have community health workers. The hospital has community health workers. The MCO has community health workers. Primary care has community health workers. The community-based organization has community health workers. What would it look like for us to have shared care planning across institutions in order to provide better coordinated treatment for this individual? And that's a form of data sharing. It's actually under the auspice of treatment, but it enables partners to, again, think about how are we working together and how can we provide more coordinated care to the individuals in our community.
This is wonderful dialogue. I am just having so much fun watching the questions and the comments, and I'm going to throw a couple of them out to Shelley and Victor to address. We're very interested in how you will partner across sectors in the audience and what you're interested in, and you've already submitted some wonderful themes. There is an article that describes Project Restoration in detail, the structures, the outcomes, that was just released from the Journal of Interprofessional Education and Practice Online. And we did link to that so you can get lots of detail there. But Shelley and Victor, I was wondering if you could specifically speak to how did you model trust and build that authentic connection in the collaborative itself? And there's a theme around who leads the collaborative and what were the practices you put in place. And Shelley, I wondered if you could start.
Sure. I'll reference, I see the question from Michael where he says the mention of actual leadership, who takes that on, since so much of the discussion is building transparent process. Isn't leadership necessary? I would say, Michael, you are spot on. It rises and falls on the committed leader of that coalition, especially at the beginning. There has to be someone who at the beginning is carrying that and willing to do whatever's necessary to build that trust with all the people around the table. Like I said earlier, at the end of the day, it's about the relationships that are built. And so most likely this is going to get launched on a person's leadership capital. And I think the way you build trust between partners isn't dissimilar to the way you build trust if you were entering into a new friendship or even a new dating relationship. You go above and beyond to show that you're trustworthy. You prioritize responsiveness in agendas and follow-up. You prove your trustworthiness again and again, and over time that heals old wounds and allows you to move forward. I remember one in particular, we were going to do a press release about the project, and a corporate PR person wrote this whole press release and made it sound like it was all the healthcare system's project, and we were solely responsible for the outcomes and the results. And luckily, I caught it just in time, because just that, I think, would have, caused it to dissolve and would have destroyed the trust with the community partners that we worked so hard to build.
We'll also just add, it's just important to model what vulnerability looks like. Oftentimes that's something that we expect as we engage patients in the community around their complex health and social needs, but we don't necessarily display that same level of vulnerability among colleagues and among organizations. And so, modeling even what it means to talk about, shortcomings, to talk about, failures, right? Times when we have not been able to reach, goal X for whatever reason. And so modeling what it, means to even have that be a part of the conversation. And I think, that is one characteristic that, really draws people to the table and help individuals understand that this collaborative is different. This collaborative is something different from, those in the past, and that, we're really talking about, the nitty gritty and what it really takes to move this work forward. And so I think talking about, vulnerability, shortcomings, and just, past times where we've perhaps stepped on individuals' toes. Shelley, you made the comment around, that press release that, did not go out. We can talk about an experience where the press release did go out and we offended community partners. And so, how are we having that dialogue with partners, and, how are we just being transparent about our shortcomings in that area? And I think those type of conversations promote that building of trust.
That makes me want to add one more item, just listening to you, Victor, and that's around the careful preparation and orchestration of the meetings. I know that sounds maybe like a pedantic detail, and we all know how to run a good meeting, but really looking at it through the filter of sharing power, of transparency, of collaboration. I remember one of my early meetings, a coach afterwards made the comment, you need to learn the 80-20 rule, because most of me and my team were dominating the conversation. And so, then we had sort of this secret little, remember 80-20, when one of us was getting a little carried away. But it's making sure that, there's time at the end of the meeting for every partner to give perspective and feedback and concern, and that you're really sharing that platform and that space. And it comes down to even your agendas and how you plan them.
That's great. Great dialogue. There's another theme of questions around scarcity. So it might be partners feeling competitive with each other and not sharing workflows or information, or it might be capacity. So once you start building these collaboratives, what if the agencies don't really have the capacity to take on and meet the needs? So I wondered if both of you could speak a little bit to how you addressed competition and scarcity in the collaboratives.
So I think, that's a great question, and it comes up a lot, obviously, as folks are trying to move these, complex issues forward. In terms of, scarcity of resources, oftentimes, what we've seen in, the community is that individuals are taking stock of resources from their own institutional lens. And so, from an organization, what can we do, or what don't we have the, resources to do? In these conversations, we like to force people to kind of think from a higher place. And so from the community's perspective, what resources do we have, or what resources don't we have? And so it's not just about, the one organization in its silo, but how do we start to take stock and better understand what resources that we have across the board, so that no one organization feels like, they're being pointed out, and recognizing again that this is a community problem that we're seeking to address. And that's hard for folks to do, to take off their institutional hat and recognize, as a member of this collaborative, we're operating from a different space. We're operating from the lens of how do I improve the welfare of, the community and the population at large. And so it can be challenging, but that's definitely a part of the conversation that we introduced very early on as we think about, forming the collaboratives, who's included, who's speaking, when, about what particular topic, and how do we amplify, the voices of individuals in the room, and often take stock of individuals who are not in the room. And so being mindful of those dynamics help individuals to feel more included as the dialogue progresses.
And I would add, in Lake County, it's certainly that particular project and that work that is just, continuing to expand and grow. It certainly falls into that category of scarcity. It is not a wealthy community. And when the partners say that they're stretched and have nothing more to contribute, they mean it. It's not a story. It's true. And so with this project, the way we began the project, we did not ask for any additional resources. Basically, the messaging was, we're all already getting paid to work with these people, or we could be. We're already doing the work. Let's just have a conversation about doing the work more effectively together. So I think, of course, eventually additional resources did come. And if you really want to expand in some innovative spaces, you certainly need some resources to do that. But to begin with, if you think back to what I said around constraint, the first conversation is, we're already working with these individuals. There's case managers from 3 different agencies who supposedly are assigned to the same person. Let's just have a conversation around aligning that. And then I also would say, around the conversation of scarcity, it goes back to the question earlier around leadership. And that is to if you're the one leading the coalition, if you're saying, I'm going to take this on and get this started, would be to check yourself as well. All things trickle down. So whatever attitude and posture the leader of the initiative is taking will be evident. And I know that I personally did a lot of personal growth work around non-ego-based leadership when I began this, working with this project initially. And I had to check in myself, where was I being overly competitive? Where was I not willing to share power? Where was I wanting to maintain control? And how was that in subtle little ways trickling out in the way that I led the work? And, sometimes the best way to negate those challenges around scarcity and competition is to check them in yourself first.
That's really
and that's a great point, Shelley. It's important for individuals to kind of do that self-reflection and also that organizational reflection as well. Sometimes I liken it to, driving a car. Sometimes if you're driving a car in the front seat, you're laser focused on, getting to a destination, and that's all, that you have on the top of your mind. And sometimes, you put on the blinker and you go to move into a different lane, and lo and behold, there's another car there in that lane. And so really, that's a blind spot, right? And you might have people in the back of the car say, hey, that's a blind spot, and you recognize that it wasn't through you trying to do harm to individuals in the backseat of the car, but it was just a blind spot that you have to better be able to account for. And so, we all have them as individuals and as organizations. And so as many data points that we can get, whether it's from those in the front seat of the car, the back seat of the car, or just another car all together, is helpful in terms of helping us to see our true picture in the state that we are.
It's very helpful. There's quite a few questions about the 4-quadrant metrics, what recommendations would be for evaluation, and what to start with. I'm just going to briefly address that. So having worked with that framework, it's very helpful to identify, as Shelley and Victor said, what matters, what metrics matter to the group. But if you hit all 4 of those quadrants in a cost metric, a utilization metric, a quality improvement metric, or a process improvement where you're measuring actual movement of the collaborative. So for example, the project restoration, they went from not having resources for homeless folks in their community to actually opening a 10-bed transitional housing unit in their community called Restoration House. That's a process metric. And then capturing the patient story so you can share that heart connection with people who will understand that perspective, as well as provider satisfaction can be really helpful. Evaluation is an emerging topic in the field of how do we evaluate rigorously these collaboratives, and I think we're all learning together in that space. Shelley and Victor, is there anything else you would add to that? I'm trying to address 4 different questions together.
I would just amplify.
You did a great job, Lauren.
Yeah, Lauren, you did a great job. And I would just amplify the importance of the patient story and really using that as a way to drive change, both through organizations and even as collaboratives are being formed. Patient stories, they really humanize, data, measures and outcomes, and really forces individuals to put the patient first and to put the needs of people first. And so I would just amplify that particular tool as a way to really galvanize individuals and groups.
Then I'm going to quickly ask you one question before we move to close. There's also a group of questions that are themed around how do individual community organizations get a seat at the table? How do you intersect if you're starting from the community or you're from a smaller organization or you're not like the big, powerful healthcare gorilla in the community? How do you start?
I would love to mention this, to speak on this one. So the work in Lake County was actually, it was a bit of a simultaneous, I think, direction of attention, but technically it did not start with the healthcare system. It started with the mayor of the city of Clear Lake, which is a small city, who began to convene conversations and with others of the community leaders, and happened to invite the healthcare system. And so, I think it absolutely, the conversation can begin that way. It's about convening, I think, thoughtful discussions, having good research, and then finding those like-minded individuals that are in the larger health systems, which is really how it began there, for one example.
Yeah, and our motto is that, we create a big table. And so, we give a lot of thought to who does this question or who does this particular topic impact? Who will have an interest in this conversation, who's impacted by this conversation, who's consistently at the table, but also who's perhaps is not at the table, who, are oftentimes folks who are left outside of the room when conversations are being brought up. And so, again, from huge hospital system to community-based partner to, behavioral health organizations to community-based organizations to the shelter to, everyone in between that touches the individuals that we work with, they are a part of the conversation and they are invited to the table. And once there, again, that's when that frank and transparent dialogue starts to begin. But initially, it is very much, creating a big table for all partners who have an interest in the topic and who touch the patients that we work with.
So many great questions, and we'd love to keep going. I'm going to move us along to highlight some additional resources, and we'd be glad to connect with you to continue the conversation. Next slide, please. So we do have a conference coming up next week in Memphis where you can meet all kinds of people from around the country who are interested in complex and vulnerable populations and this kind of approach. We would love to have you join us or check out the resources on our website. Next slide. Next slide, please. We also have started a complex care group on LinkedIn, which we hope you'll join. It's a place to continue the conversation. We have a website, the Blueprint for Complex Care, and also the playbook, the Better Care Playbook that Catherine mentioned at the start of the conversation, which are all rich with free resources and tools and articles and ideas about how you can inform your cross-sector or partnerships across the community. Next slide, please. There are also several articles published that give a lot of detail about how these collaborations were built and the principles and outcomes from those. There's also a new guide that was just recently released by the California Healthcare Foundation, which is a hands-on guide to cultural integration and community health partnerships, which we wanted to highlight as well. All of these are open access and free on the web. So we want to thank you so much for joining us today, and thank the Better Care Playbook and the National Center for Complex Health and Social Needs for sponsoring this webinar, and thank all of you for your interest. I really believe that cross-sector community partnerships is key to how we're going to heal our communities, as well as the root causes for complex populations. And we're so excited to continue to share with you the lessons we're learning, the tools and resources to facilitate your development and growth of this work in your community. Thank you so much for joining us today.